Uh, Thank you. It's wonderful to be here to share some of my experience with Remplissage. I'd like to thank the organizers for the opportunity to come to this meeting. It's my first time. We actually will be coming back in August with my family to spend some vacation time in Greece. So if you have any suggestions of where we should go, please let me know. There we go. So over the next 10 minutes, I'm really going to focus in on three particular areas of this presentation. First, I was just going to go into what is Remplissage. I think everyone probably understands what that procedure is. The question is, should we be doing Remplissage for everyone? And I'll give you the answer right now. It's no. But then who should we consider doing the Remplissage for? So what is the Remplissage? I think we've heard it several times today. It's an insetting of the posterior capsule and tendons into the Hill-Sachs defect, as you can see here. And eventually you get healing of the capsule into the Hill-Sachs defect, which then makes it extra articular and hopefully decreases the risk of engagement. So now the question is, should we be doing this for everyone? And obviously the answer is no. But then who should we consider doing a Remplissage for? I think each one of us has to decide how we manage complex shoulder instability. I tend to manage it based on the glenoid side first. So I'm a glenoid side first person. Some people like to look at it first on the Hill-Sachs side, so I look at it more on the glenoid side. And one of the most important values to determine, and each of us has probably our own value that's important to us, is this critical amount of glenoid bone loss. We know that when the value surpasses that, we're going to do potentially a bony procedure. And when it's under that, we're potentially going to consider a soft tissue operation. So now what is the important value for critical bone loss? If you look in the literature, there's a lot of variability here. You can see there's a 10% value, 13.5% is a number that's thrown around commonly, 15, 20, and 25%. I think the one thing that we do know very clearly is as glenoid bone loss increases, the recurrence rate with soft tissue procedures also increases. And we also know eventually there has to come a time where we switch from a soft tissue procedure to a bony procedure. And I think what a lot of the research out there is trying to tell us is what is this one particular value of critical glenoid bone loss? And I think what we're going to find out is there's not going to be one value that we can apply for everyone. We know the anterior shoulder instability is multifactorial. You have patients that have age-related issues, activity, collision, contact athletes. We know that in a 18-year-old male who plays rugby, his critical bone loss may be 5% versus a 50-year-old female who does an office job, her critical bone loss may be 25%. So eventually, artificial intelligence and AI is going to tell us what the critical bone loss is for each individual patient. So we shouldn't be looking for that for our patients right now. So saying all that, what do I find valuable? My personal threshold right now is 10%. And I think each of us has a different value. I think it's probably based on evidence-based management and our personal experiences of what value we choose to use for glenoid bone loss. So mine right now is 10%. If they have greater than 10%, I do an arthroscopic Latarjet. And obviously a bone block procedure is also validated in the literature. Now, certainly from a biomechanical perspective, I'm very biased. I believe in the Latarjet operation. I think biomechanically it's superior to a bone block because of the sling effect. I think also the clinical studies, if you look at a lot of the systematic reviews, also show that Latarjet is a very, very, very good operation. So this is actually a very interesting paper looking at Remplissage. So this is Pascal's paper, and they had 133 patients that they did a Bankart repair on and a Remplissage. And then they divided these patient populations up into two groups. They had group 1, which had less than 10% bone loss, and then group B, which had greater than 10% bone loss. The overall recurrence in the whole group was about 7.5%. But what's interesting, in the patients that had greater than 10% bone loss, they had a significantly greater failure and recurrence rate. So even the Bankart and the Remplissage is really dwarfed by the experiences of, or the association of glenoid bone loss. So glenoid bone loss is probably one of the most important factors to consider when we manage patients with shoulder instability. They did a multivariate logistic regression analysis, and they found the two factors that were associated with failure were glenoid erosion greater than 10% and also a young age. And this makes a lot of sense. They found, interestingly, in those 7.5% that had failures, they did an arthroscopic Latarjet and every one of those patients, and those patients remained stable and did not have a failure after. So I really believe the Latarjet is like the Superman of instability surgery. It solves a lot of my problems. So critical bone loss, greater than 10%, we're going to do a bony procedure. That's my particular solution. But in less than 10%, what are we going to do for that patient population? So this is probably one of those landmark papers that had an influence on everyone really over the last decade. And I hesitate to say this, that maybe it threw us off for a decade, and that maybe it's not as important as we once thought. So in this paper, they describe the off-track and the on-track lesions. In the off-track lesion, you're going to do a Bankart and a Remplissage. In an on-track lesion, the recommendation was those are the cases that you have to do the Bankart. But the question now in 2024 is, should we be adding a Remplissage for this patient population also? This is a paper that supports that excellent paper, Peter Domos. He looked at arthroscopic Bankart repair and Remplissage in patients that had on-track lesions. So these are not the off-track lesions, these are the smaller sized Hill-Sachs defects. And what they found, a significantly lower recurrence rate when they added the Remplissage in these patients with the on-track lesions. These were collision and contact athletes. You can see that there. Another great paper published in JSCS in 2023. They had subcritical bone loss, and what they described as subcritical is 15%. All of these patients, once again, had on-track lesions, so not really indicated for the Remplissage, but they did it. They had 127 patients that they did a Bankart only, and they had 56 patients in these on-track lesions where they chose to add the Remplissage. And let's look at the recurrence rate. So the recurrence rate in just the Bankart alone, 11%. The recurrence rate in these on-track lesions when you added a Remplissage, 2% or under 2%. So you can see that maybe on-track and off-track is not as important as we once thought. The addition of the Remplissage in anybody that has a visible Hill-Sachs defect significantly decreases the recurrence rate. So when should we be doing a Remplissage? So in a patient that you decide is a candidate for a Bankart repair, so typically less than 10 or 15% bone loss, the question that I ask myself now is, can I see a Hill-Sachs defect, whether I can see it on the MRI, the X-ray, or the CT scan? If I do not see a Hill-Sachs defect, those patients get an isolated Bankart, and maybe I should consider the DAS, but right now I'm doing an isolated Bankart repair. If I can see a Hill-Sachs defect, whether it's on track or off track, those patients get a Remplissage, and certainly the new literature would support that. So maybe in 2024, we don't have to spend all this time measuring the Hill-Sachs defect. The fact that we actually have one should indicate a Remplissage procedure. So in summary, pick a critical bone loss value that's important for you. For me, it's 10%. If it's greater than 10%, my preference is to do an arthroscopic Latarjet, but bone block's a very good operation. Distal tibial allograft, iliac crest, distal clavicle. I just learned about equine graft too, so maybe I'll throw that into my armamentarium. But in less than 10% glenoid bone loss for me, if they do not have a Hill-Sachs defect, they get a Bankart procedure. Now, if they have an engaging one, I think the evidence would show you could do a Bankart and a Remplissage, but remember, the failure rate is higher in this patient population. And then so in those patients, I consider the Latarjet, but now if they have a Hill-Sachs defect that's non-engaging, those patients probably should be considered doing a Remplissage. So it all comes down to, if you see the defect, we should probably fill it. Thank you. I want to take this opportunity to invite everyone to Vancouver in 2026. We were very fortunate to win the bid for the International Congress. It's occurring in the city of Vancouver, which is on the west coast of Canada. It's a beautiful city. It's right on the water with the mountains in the background. So if you enjoy skiing, you can go skiing on the glacier. If you enjoy playing beach volleyball, you can play volleyball on the beach. So I welcome everyone to Vancouver in 2026. Thank you.